And now I go to the pod, right? Okay, welcome everybody. It's really amazing to see all of you showing up on a beautiful afternoon. And I'm hoping the next hour will be informative and entertaining as we move forward. This webinar is brought to you by the New Hampshire Training Institute on Addictive Disorders. You can access the recording of this webinar in the future, where it will be archived at www.nahatica.org. After completing the webinar, please make sure that you email Nahatica at www.myfairpoint.net if you would like a certificate. There's going to be a short quiz that will be emailed to you, and you would have to return that. You'll receive a certificate worth 1 CE once you've completed and passed the quiz and paid for the webinar, if applicable. Through co-sponsorship with the New Hampshire Training Institute on Addictive Disorders, this 1-hour event is approved by the New Hampshire Board of Licensing for alcohol and other drug use professionals. If you have any trouble viewing the webinar, audio problems, or have any technical questions, please contact, how do you say that, Natia Dad? Please contact NHTIAD at 603-225-7060. You can find this phone number on the bottom of the screen throughout the presentation. Please enter any questions that you may have regarding the materials that you see today in the chat box at the bottom of the screen. I will answer questions after the webinar is over, and they will be emailed to you. If you are viewing this as an archived event, the chat box option won't be available to you. However, you may email your questions to nhtiad@myfairpoint.net. Okay, we're going to get started. This is on medication-assisted treatment. My name is Mike Gaudette. I am Director of Quality Assurance at Albert Counseling Services in Norwell, Massachusetts. I have been doing this training for approximately, maybe 6 years now, so it's something that's near and dear to my heart. Over the course of this hour, we're going to talk a little bit about some attitudes and beliefs that we all might have that contribute to our understanding and willingness to work with medication assistance. We'll talk about some of the current medications that are available, who would be an appropriate candidate for medication, some co-occurring disorder issues that need to be taken into consideration, and the role of the clinician. Obviously, in an hour webinar, you won't get all the information that you'll need to become an expert, but at least you'll feel better about yourself at the end of the hour. So in terms of the attitudes and beliefs, there's a couple questions that are going to show up on your screen. And what I'd like you to do is to consider typing into the chat box your thoughts about those questions. And I'll try and read as much of them as I can so that we can get an idea of what's out there. Starting with, what do you believe is the general attitude about the use of medication for recovery? Do you think it's favorable? Do you think that people are tolerating it but really don't like it? Or do you think that there's a very strong opposition to the use of medication? The second question, and you can answer all or some of these or just one of them. The second one is, what are your personal and professional beliefs about the use of medication in recovery? And then finally, if your job required that you supported the use of medication in recovery, how would you respond to those who oppose it? And while you're thinking of your answers, let me just give you a little bit of my experience so that you'll know where I'm coming from. I've been working in the field of substance abuse since the late 70s, and for the first 20 years of my career, I absolutely opposed the use of medication. I thought that methadone, and even Antabuse to some degree was nothing more than a substitute, nothing more than another way to not own the addiction recovery process and then rely on some medication to try and take care of you. With respect to methadone, I just thought that they were getting addicted to something else, and that it made no sense to use methadone to treat opiate addiction. Then I was laid off in the late 90s, and within a week of that layoff was hired as director of a methadone clinic. So within a week, I all of a sudden became an expert on methadone, and verbalized that I totally agreed with it as an approach. My unspoken motivation for taking the position, well, there were two. One, I needed the money, but the second one was I wanted to go into that clinic and teach people the truth about recovery, and that medication was nothing more than a crutch. Needless to say, I've changed, and part of that comes from looking at what was going on in the clinic, listening to what the clients were saying about their recovery, and observing some of the changes that occurred in their lifestyle, and just the degree to which they became productive members of society. So I share that with you because there may be some of you here who have a negative thought about the use of medication, and I just want you to know it's okay. My goal today is not to change your attitude, it's just to give you the information. What you do with it is going to be up to you. So we've got a couple comments already that I'd like to share with all of you. One is that the first thought is that they think ideas are changing toward the positive use of medication in recovery. So it sounds like you're thinking that people are beginning to embrace it more. Whereas another one believes that there's a very strong opposition to the use of medication. And then another comment is that there's major resistance from 12-step philosophy. And it's interesting to see that the continuum of thinking here from, people are beginning to feel positive about it to that there's still a very strong resistance. And to be honest with you, you're all right. So I'm really impressed by the audience so far. There are a number of myths that are associated with the use of medication that contribute to the belief system. And so I want to explore just some of them to kind of address it a little. For example, medication is not part of treatment. We often hear that from people who say that they're really not in recovery because it's the medication that's taking care of them. Well, what they have found over time through study after study is that medication can be an effective part of treatment, but not treatment in and of itself. And if you think about the diseases, there are many diseases that use medication to treat the disease. And addiction is just another disease that allows for the use of medication to treat. Medical decisions for the use of medication has to be made by trained and certified medical providers. So if in order to understand the validity of the use of medication, you need to embrace the fact that it's physicians, people who are trained specifically in medication, who are prescribing the medications. And then finally, the decisions about using the medications are based on objective assessment of the individual client's needs. And I think that's probably the most important point, in that not everybody who has an opiate addiction, for example, is appropriate for methadone or Suboxone or Vivitrol or any other medication that's out there. And there is still a percentage of people who are quite capable and quite appropriate for embracing recovery without medication. So that kind of tells you a little bit of where I'm coming from too. I don't believe that one size fits all. That would be a disservice to a number of people. Another myth is that medicines are drugs, and that comes from a language issue, and that's that we have a lot of problems with the way that we communicate in our field. Is it dual diagnosis or co-occurring disorders or comorbid disorders, or, we're not quite sure what to call things. And here is an example of that. Medication is prescribed. And in order to get medication, you have to go into the pharmacy with a prescription in order to get it. Drugs, you get by going behind the pharmacy. So if we can kind of think of it that way, then medicines are medications. They're prescribed, it's controlled, it's monitored, it's observed, with goals intended, as opposed to drugs, which are there for other reasons, other unhealthy reasons. Another myth is that AA and NA does not support the use of medication. And in fact, that was one of the comments made earlier, that there's major resistance from 12-step philosophy. It is absolutely true that there are meetings, chapters of NA and AA, where if you were to share that you are on any kind of medication, whether it's for addiction or for mental health disorders, that they would question, if not outright deny you your recovery. I know of clients who go to specific meetings where they cannot make the coffee, they cannot vote, they cannot chair meetings, they can't even set up the chairs at those meetings because they're not considered to be in recovery. So while some specific chapters are not tolerant of methadone, for example, the literature and founding members do not speak or write against using medications. So this is coming not from the philosophy of the 12-step programs, but from the members. What do you think about that? You agree with that statement? Another myth is that methadone or medication-assisted treatment is not effective treatment. Medication-assisted treatment, the medications that are used to treat addiction, had to demonstrate the same level of effectiveness as all other types of medications for other diseases in order to get FDA approval. So it wasn't just, let's try to give them this medication. It went through a whole process of testing and controlled, what do you call that when you want to, it's escaping me. But what I'm trying to say is simply that it was not just put out there. They studied the effectiveness of that medication before it was approved. We tend to have a biased perception. Patients who improve are the ones that are forgotten. The old squeaky door gets the oil deal. We hear the bad stories. We hear the troublemakers. We hear about the people who abuse medications such as methadone, rather than the thousands and thousands who get their lives together and become productive members of society. So in some respects, our understanding of it, unless we work with it, our understanding of it gets skewed. And then another myth is clients who are not using drugs at present do not need medication-assisted treatment. And I think looking at people who have been in prison, for example, people who are locked up for years and do not access illegal substances while in prison, the moment they step out, they become at risk of relapse. And the statistics support the fact that more than half of those inmates will relapse within 1 month of release. And there's lots of different reasons for it, and I've got them listed, such as peer pressure, family pressure, tensions of daily life, etc. So we know that people who have been off illicit drugs for a long period of time are still at risk of using those drugs. Why should we wait until they pick up before they're given medication that would help them to not pick up? And that's the rationale behind medicating individuals who are drug-free at the moment, but at risk of relapse. One of the questions we often get is, why bother using medication? Isn't abstinence enough? Again, let's look at it as addiction as a disease. It's not a weakness. It's not a moral flaw. It's a chronic medical disease that damages the brain and alters both thoughts and behaviors. There's a physical transformation of the brain that occurs as a result of their drug use, and talk therapy is not always enough to address those changes. Recent advancements in understanding neurobiology will lend credence to the use of medication along with psychotherapy for better results. And that's something that I really want to emphasize. Nobody who works with the medications for recovery is suggesting that the medication alone is enough for recovery, because all that will do is assist them in not using the illicit drug. What it won't do is address all of the damage, the psychological and the mental and the behavioral and damage that has been caused as a result of the illicit use. So for medication assistance to be effective, it's highly recommended that in addition to it, and in fact, in most cases, it's required that in addition to it, you also receive therapy to work on the related psychological and behavioral issues. I think I went backwards. No. Medications result in the rebalance of brain chemistry that block the high, and they reduce the potential for relapse. And there's been an evolution in the understanding and treatment option parallels, which parallels that of other chronic diseases. In other words, people with diabetes or hypertension or asthma, treating those illnesses just with medication only goes so far. They have to learn nutrition. They have to learn how to take better care of themselves. They have to learn how to cope better with stress, etc. So just the medication alone is not sufficient in taking care of those illnesses. The same is true with addiction. And this is really important. There is no medication out there that will cure people from addiction. There is nothing that will make them a non-addict. What it does is it corrects the damage that occurred as a result of the illicit use, the physiological, neurophysiological damage, allowing them then to feel normal, to be normal, to respond normal, and now they have to learn how to live in that normal life, in that normal world. So let's look a little bit into the brain. We're talking about addiction being a brain disease. It's important to know that addiction as a brain disease is not just a cliche, it's a reality. Drugs acutely modified mood, memory, perception, and emotional states. I don't think I have to prove that point to anybody here. And using drugs repeatedly over time changes brain structure and function in fundamental and long-lasting ways. Addiction then comes about through an array of neuroadaptive changes and the laying down and strengthening of new memory connections. So what this is saying is that there are physiological changes that occur in the person's brain as a result of their illicit drug use. Drugs cause surges in dopamine neurotransmitters and other pleasure messengers in the brain. And the brain then adapts, and then these circuits desensitize. What that means essentially is this. A person takes a drug, it causes a surge in dopamine into their brain, moving from one neurotransmitter to another, causing them to feel elated, causing them to feel excited, and high and happy and all of that. And what the brain learns over time is that it doesn't have to release those neurotransmitters on its own, because this individual is introducing a substance that's going to cause it to happen by itself. So the brain is learning to shut down its capacity to release those neurotransmitters. Well, what happens if you don't use something over time? If you don't use it, you lose it. And that's essentially what happens with those individuals. They lose their capacity to release those certain chemicals, neurotransmitters, and therefore become reliant on their drug of abuse to create the feelings that they're seeking in life. The receptor sites in the brain are altered, and that's what I'm talking about. And there are different kinds of receptor sites. Now let me explain a little bit about receptor sites so that we're all on the same page. What I'd like you to do as you're sitting in front of your computer is cup your hand as though you're holding a baseball and have the palm of your hand facing up. Call that a receptor. Your brain has billions of these things in there, in your brain. And between two brain cells, a chemical is released, and it goes looking for the receptor that has been designed specifically to receive it. So your brain, for example, if you are trying to relax, it will release endorphins, and the endorphins go looking for the receptors that get activated by the endorphin. When heroin enters the brain, by the time it goes into the brain, it enters the brain in a state that almost exactly resembles those endorphins. So the brain is thinking, I don't know why it does this, but it's thinking that it no longer has to release endorphins because now it's getting it from the outside. And that's an example of how it alters the receptor sites. So here's your brain. I'm sure they're not colored like that, but that's just to illustrate the different areas in which we have memory, judgment, movement, etc. And the area that's most affected is that reward area. I'm colorblind, so I'm not entirely sure if it's blue or purple or gray, but it's somewhere in there, in the middle of the brain. Now, this slide just quickly shows you how cocaine changes the brain with respect to glucose metabolism, so that even 100 days after abstinence from cocaine, there is still damage. There is still a change in the brain's capacity to metabolize glucose. So I mentioned dopamine earlier. Dopamine is a hormone, and it's a neurotransmitter. When it's working normally, it gives feelings of pleasure, and it's also involved in decision making. When it works abnormally, it leads to craving, depression, and difficulties with decision making and some memory problems. So let's look at alcohol. How is the brain hijacked by alcohol? There are essentially 4 cast members in this play. The first is dopamine, which makes you happy. The second are those endogenous opioids, those endorphins that we naturally have in our body that make us feel euphoric or relieve our pain. Then there's glutamate, which excites us. It's kind of the accelerator. And then finally there's GABA. GABA is the inhibitor neurotransmitter. It slows us down. So those are the four cast members, if you will, of the process for hijacking the brain through alcohol. First, well, a little fancy slide there. First, alcohol is consumed, And at that point, endogenous opioids are released, which cause you to feel good, which give excitement, makes you feel no pain, makes you feel euphoric. Then dopamine is released. That helps you to feel happy. And then the brain learns and remembers the good feelings that were brought on by those opioids and the dopamine and seeks to repeat the behavior. So you can see how addiction is starting to build. It learned very quickly that if a person takes a drink, they're going to feel better, they're going to feel happy, they're going to be in love with the world, they're going to have a good time and feel excited. And that's how the reward process, the reward pathway begins to get out of control, off balance. At the same time that that's happening, GABA, remember that GABA is an inhibitory, it slows us down. GABA is created, is increased, and the glutamate is overridden by the GABA. So you've got, think of it this way, you've got your foot on the gas pedal at the same time as you have it on the brake. Now, I don't know how many of you are into cars, but you can imagine that that would create a problem with going forward. And that's essentially what's happening here. You've got the inhibitor and the excitatory at war with each other. In response, the brain tries to correct the imbalance by increasing sensitivity to the glutamate. And over time, what happens is it destroys our balance. It destroys our ability to upregulate and to get balance again. If the individual drinks after this has happened, it begins to take more alcohol to override that glutamate system and to feel the same level of intoxication. Okay? So now we're not only beginning to see addiction begin, but we're now beginning to see it progress. And with alcohol and with alcohol addiction, what happens over time is that tolerance for the drug builds up, essentially meaning that a person might feel tipsy after 1 or 2 beers. Now it's taking them a 6-pack or a case of beer to get that same desired effect. This is a clear indicator that the person has physical dependence on alcohol. The good news is alcohol addiction is a treatable disease. What we know specific with alcohol is as that disease progresses, that tolerance for the alcohol will then decrease, so that perhaps they work themselves up to a case a day or more habit. Now they can't even drink a glass of beer without getting intoxicated. So their tolerance for the alcohol has decreased. Medications for alcohol, there are several things there are 3 ways that medications will help to address the alcohol issue. One is it can reduce post-acute withdrawal, and I'm hoping that you all know what post-acute withdrawal symptom is. If you don't, make sure that you leave me a little note in the chat box and we can address that. Another medication will block or ease the euphoria from alcohol. And then there's another medication that discourages drinking by creating an unpleasant association with it. So let's look at what those medications are. Disulfiram or antabuse has been around since 1951. And essentially what it does is it interferes with the metabolic process and results in a buildup of toxic substances in your blood, acetaldehyde. This can cause nausea, vomiting, sweating, flushed skin, and if it gets serious enough, people can even die from drinking on top of disulfiram or antabuse. This has been known, it acts as a deterrent, not a blocker, but a deterrent. So people know that they're going to get very sick if they drink alcohol, and in fact, if they're on antabuse, they shouldn't be using any mouthwash with alcohol in it, or aftershave or cologne that would have, or anything that has alcohol. Even topically applying it on your skin, a person can get sick. So it's a deterrent, and they know that they're going to get sick if they drink, if they've taken their antabuse. Then there's naltrexone, and I don't know how many of you have heard of Revia. Revia has been around for at least 2 decades, to my knowledge. I remember when it came out in the mid-90s. Revia is an antagonist substance, and what's meant by antagonist? Remember that cup that you're holding the baseball, but you can go back to putting your hand there and hold that baseball in your hand. An agonist medication will go into the cup and will activate it fully. In other words, when a receptor site is activated, it is free to perform the way that it's intended. So your opioid receptors, for example, are free to cause you to feel euphoria, cause you to address pain, to relieve some pain, etc. So that's what an agonist medication would do, or an agonist substance. An antagonist substance, such as Revia, sits on top of that receptor so that nothing can go into it. So it's like you can't catch the ball because there's a cover over your hand. And Revia, or naltrexone, is an example of an antagonist substance that will block the impact or block the effects of the drug, such as alcohol, that they're taking. In order for naltrexone or Revia to be effective, they have to take it daily. Vivitrol is an injectable form of naltrexone. The injection it's in the gluteus maximus. It lasts for about 30 days. It will help to decrease cravings for alcohol and for opioids. Prevents, because it's an antagonist, it prevents the alcohol molecule from binding to the receptor. So if they drink, they're not going to feel it. They're not going to get the effects of that. And from that, the user typically begins to decrease use because they're not getting what they want to from it. And another medication is acamprosite or Campril. This repairs damage to the brain that was caused by the alcohol. It restores and rebalances normalcy to the GABA and the glutamate system, the braking and the acceleration pedal. It improves cognitive skills, ability to learn new coping skills, etc. It was approved by the FDA back in 2004, 10 years ago. There are other medications that aren't used as much, but they certainly can be prescribed if the ones that I mentioned earlier were not effective. Topamax, Surzone, Zofran, Lyarsol. These are medications that have shown promise in reducing the cravings and helping to relieve some of the by lowering the dopamine, making it people feel more normal. They're not approved yet by FDA. They're still in the study stage, but they at least look promising. So there may be more choices. With sedatives, there is no FDA-approved medication right now to treat sedative addiction. However, there are meds that are effective in treating anxiety that follows the cessation of use. So anti-seizure and anti-epileptic medications like Neurontin are often prescribed. Seroquel, Risperdal, for example, or Lexapro, etc. Again, they're not approved by the FDA to treat sedative addiction, but they've been known to treat some of the side effects that some of the symptoms that occur when the person stops using them. So a poll question is coming up at this point, and I'm going to flash it onto the screen. And the question is, among other things, medications for alcoholism can block or ease euphoria from alcohol. And if you just take a moment to click either true or false based on what you've heard so far, and as soon as you're done with that, we'll move on. So all four of you said true, and all four of you get a standing ovation. You can't see me, but I'm standing for you right now. Okay. Good job. Either you're doing a good job listening, or I'm doing a good job talking, or we're doing a good job together. So going back to the presentation, takes a second to pull up. Here we go. The good news, I don't know if you can see that, but it says the good news is, this is going to talk about opioid addiction. Opioid addiction is a treatable disease as well. First of all, in terms of treating opioids, it's very similar to treating alcoholism and other chemical addiction for which there is medication being prescribed. It's learning how to live life again, coping with situations as they come up during the day, and in addition to that, because the brain has changed, it has altered, there has to be something to address those changes. Now, I want you to understand, I talked earlier or mentioned earlier that medication alone is not effective enough to treat addiction. And in many cases, talk therapy has not been effective enough either. I think all we have to do is take a quick look at some of the some of our dropout rates and some of the recidivism rates and relapse rates, and we'll see that I think the best we can do over time is about 20% still in recovery a year after they finished treatment, regardless of whether they were on medication or not. And in order to understand that, I want you to bear with me a second. Change is rarely ever linear, okay? And I'm going to ask you to take a risk with me. Although I can't see you, I'm going to trust that you're doing this. I'm going to ask that you hold your hands about 6 inches apart. And when I say go, I'd like you to interlace your fingers so that the thumb from one hand is first, the thumb from the second hand is second, and then your fingers all the way down. Just when I say go, join your hands like that. Okay? Go. Now be aware of what you're feeling as your hand is clasped in this order. Most people say they feel nothing. It feels normal. They may feel warm because their hands are together, or they may feel comfortable because it's a way that they fold their hands when they relax. What I'd like you to do now is to separate your hands, and I'm going to ask you to interlace them again when I say go, but this time I'd like you to interlace them in the other order. So whatever thumb was second is now going to be first, all the way down to whatever finger was last is now going to be next to last. All right? So go. And what I'd like you to do is be aware of what that feels like. And if you got a moment, just throw a word up in the chat box on what you're feeling in this new order. Okay, we got some people typing. Hold on, I'm going to see what we got. Uncomfortable, strange the second way around. We got another person is typing. Again, it feels strange the second way around. And those are typical responses. And somebody said funny they had to think about how to interlace their their fingers. And one of you is not feeling normal. So if it's any consolation, those are typical feelings that I hear from people whenever I do this exercise. It's like it's strange and unfamiliar and uncomfortable and just something that doesn't feel normal to them. If I were to say to you that from this point forward, if you were to fold your fingers in this new order from today forward, you would 100% of the time be height and weight proportionate. You would 100% of the time never, ever, ever have an illness. You would always, always have $1,000 in the bank regardless of the purchases that you make. You can buy anything you want, but you will always have $1,000 in the bank. How many of you are willing to say that you will 100% of the time fold your fingers in this new order? Do I have any takers? I couldn't commit. One person said they'd like to try it. So would I. I wish I could do it too. Somebody else said not sure. Waiting for another response here. Oh, this one looks like it might be a long response. He would learn how. Okay. Good try. Chances are none of you would be able 100% of the time fold your fingers in this new order. Partly because when we're not thinking and, something comes up and either we're stressed or we're deep in thought or whatever, we tend to go back to the familiar and to the normal, to what's normal for us. All I asked you all to do is change the order of the way, of the manner in which you lace your fingers. People with addictions have a biopsychosocial-familial-econo-spiritual disorder that has caused damage in each of those areas for which the person needs to bring about change. If you can't, with any sense of any real, my 60-year-old brain is forgetting the word, any confidence, tell me that you will always fold your fingers in this new order, then why would we expect people in recovery to only go in a straight line with respect to changing their lives? It's a process. They have to learn all of these things. They might slip and fall on the way of doing it, but they have to learn. And the use of medication in recovery will assist them in having the stabilization that's needed to make those changes. So with opiates, there are, and with all substances for that matter, there are three ways that, or three areas in which the recovery process begins. One is with avoiding the drug, and that's where using coping strategies and making those changes comes into being. Another is replacing associations, and therapy is very helpful in helping people to learn new choices, make new choices around their social environment, around their some of their behavior choices, etc. And then the use of medication to address the neurobiological, the neurophysiological changes that occurred in the brain. Medication can address many of the changes that occur in the brain. It helps helps the person to function more normally. It helps to facilitate the process of recovery. Specific with opioid addiction, there are three medications that are typically prescribed. Any one of these three. One is an agonist. Remember that an agonist medication fully activates the receptor. There's the antagonist, which blocks the opioid effects. And then there's the partial agonist, which has the characteristics of both agonist and antagonist. And there are medications in each of those areas that are prescribed. Naltrexone, you'll recall both naltrexone and its injectable form Vivitrol. Those are that were prescribed for alcohol addiction. They are also prescribed for opioid addiction. It's an antagonist. It sits on top of the receptor. It blocks the drug of abuse from entering and activating the receptor. Then there is Suboxone, which is a partial agonist that was approved in 2002, and its partner medication Subutex. Both Suboxone and Subutex are partial agonists. And then there's Methadone, which is a full agonist medication. I'll talk a little bit about those medications in a second. Let me just catch up here for a moment. You can unlace your fingers, by the way. I don't know if you did yet. Okay. So, Methadone. Do you know that for years people believed that methadone dyed your insides orange? I don't know if you knew that or not, but I know why they did that. They did that, they believed that because years ago when methadone was introduced into the system, into the medical field, it was mixed with Tang and people drank an orange substance. But they believed for years, and there are still some who believe, that it dyed the insides orange. Methadone has been the most opposed medication that exists. In fact, most people still oppose it, especially people in the recovery arena will still oppose the use of methadone. They do not see people on methadone as being in recovery. And yet, as an agonist medication, it's given in a controlled manner. It's monitored daily for a period of time before people can actually be trusted to take it on their own. And people's lives have gotten better. They become productive members of society. So there's nothing experiential or anecdotal that supports that methadone is an inappropriate or a bad medication. Part of the stigma that got attached to it is because it was created. I wish I could reach out and hand $1 to someone who knows this answer. Anybody know where methadone was created? I'll give you a moment to see if you can type it up. And I'm not seeing anybody reaching for that computer. Jude, yeah, I got somebody giving it a try. Yes. Oh, you're going to win $1. I got to somehow get $1 to you. She said Germany, and she's correct. It was created in World War II Germany because the Germans had run out of morphine, and they were able to create the substance that would help to relieve pain to their wounded soldiers. So good job. Not everybody knows that. Suboxone, by the way, let me go back to Suboxone a little bit. Suboxone is actually, there are two medications. There's buprenorphine and naloxone. Naloxone is an antagonist medication similar to naltrexone. Buprenorphine is a partial agonist medication. Suboxone was developed here in the United States. The reason that the naloxone is attached to the buprenorphine, the intent of it was to decrease the potential for diversion. The naloxone, when taken correctly, which is sublingually, the naloxone doesn't do anything to help that person in his or her recovery. It's the buprenorphine, the partial agonist buprenorphine, that helps them. Remember what I said earlier, that as a partial agonist, it has both the agonist and antagonist effects. Subutex is buprenorphine without the naloxone. And there are some people, there's a small percentage of people who have sort of an adverse response to the naloxone, an allergic response to it, and they are much better maintained on Subutex. Also, Suboxone is a Category 3 medication, which means it's not approved for the use of women who are pregnant, but Subutex can be used as long as the woman signs a waiver saying that she knows that the methadone, that the medication of choice for pregnancy to treat opioid dependence to a pregnant woman is methadone. And in terms of the effects of methadone on the fetal development and the birth of that baby, they have done tons of studies over the years. Tons of them. You can type in methadone in pregnancy and pull up a number of them. And what they have found is that roughly 60% of the babies born of mothers on methadone are born addicted. They're born physically dependent, and they get into withdrawal. They are prescribed medications that will help them to withdraw. Over the first 2 years of that person's life, there may be some delay in meeting some of the developmental milestones. But after the age of 2, there is absolutely no difference between those people born of mothers on methadone and the general population. So the long-term effects of having been born of a mom on methadone is normal life. And I just think that it's important for everyone to know that. The reason why it's preferred that pregnant opioid addicts get medication is that it certainly reduces their potential for using illicit substances. And one of the risks of using those illicits is the withdrawal process. Withdrawal from opioids can introduce spontaneous abortion. They could have a miscarriage. So it is much healthier for the opioid-addicted pregnant woman to be on methadone than to try and go it alone. If she refuses to do methadone, and there are lots of reasons why she might do that, she could be given the option of Subutex as long as she signs a waiver that acknowledges that she understands that methadone is the medication of choice, but she's choosing Subutex. With stimulants, there are no medications specifically approved by the FDA, but they are looking again at some information. Disulfiram, antabuse, for example, has been found to be effective in helping people or reducing some of the after effects of withdrawal. They're also looking at naltrexone. It appears that naltrexone may be effective in decreasing and reducing the cravings for cocaine. Now, it hasn't been approved. It's still in the study stage, but it's something that may come down the pike. And you can say that you heard it here. With respect to, and there's the cocaine. They're also looking at a vaccine, which I think is interesting. It's the TACD. That's the name of it. It binds to the cocaine molecule and then prohibits it from crossing the blood-brain barrier. What that means is, person takes cocaine, this vaccine, which is in their body, this chemical, will then attach itself to the cocaine molecule, will cause it to increase in, it results in its not being able to pass through the blood-brain barrier, and the person doesn't get high. So this is currently in phase 2 research. And if you want more information, if you type up TA-CD, you can access some information on it. Very exciting possibilities with that. With respect to hallucinogens, such as marijuana addiction, THC is stored in fat cells. Now, remember I talked about that we have billions of receptors. Those receptors are located on brain cells, and we got billions of brain cells. The space between two brain cells is called a synapse. Marijuana, heavy use of marijuana causes marijuana molecules to collect in that synapse. And I don't know if you've ever met anybody who was a heavy marijuana addict where they couldn't remember what they did yesterday. Their memory was just shot. That's because of the buildup of the marijuana molecule in that synapse area. The thought process trips as it moves along from one brain cell to the other. So there's no approved medication at this point. It is found that Seroquel has been effective to decrease cravings and reduce some anxiety. They're also looking at Lexapro and Zoloft and other SSRIs. With nicotine, nicotine is a very small molecule that upon inhalation into the lungs quickly gets into the bloodstream and reaches the brain by crossing that blood-brain barrier. Once in the brain, it binds to nicotine receptors, which results in the release of stimulants such as dopamine, which is linked to pleasure. We talked about dopamine with alcohol, if you remember. They're looking at a vaccine. They're thinking it'll be available in about 3 years, called Nicdax, and it's currently in phase 3 research. What it essentially does is it stimulates the immune system to produce antibodies that will bind to nicotine in the bloodstream and prevent it from crossing that blood-brain barrier, and therefore it cannot enter the brain. Since less amount of nicotine will actually reach the brain, there is fewer stimulants released, less dopamine is released, and therefore the smoking cessation is less pleasurable. People don't get the bennies from smoking that they were seeking, and it becomes easier to quit smoking. So it's very exciting stuff coming up in this field. I see I've got a question. I heard about an old TB med, which when combined with CBT for cravings can be quite effective. Have you heard of this? Decyclazarine TB med. I haven't. I wouldn't doubt that it's been found to be effective, since they're finding all kinds of medications that are. Let's see. Quite effective for which drug of abuse? Any idea? Cocaine. No, I haven't seen that, and that doesn't mean that it doesn't exist. And I'm really glad that you raised that up. I will look into it. I'll make sure I write that down. Someone else is typing something. We'll wait a second for him to finish his thought. And while we do that, we're going to move into who's appropriate for the medication. I also noticed that we're kind of running out of time. I'll be starting a trial with it next week. Oh, okay. I'd be really glad to hear if this is good. Now, got another comment coming. Really neat. All right. So we actually are toward the end of this, and I wanted to talk about who's appropriate for the medications. Remember I said earlier that not everybody is appropriate, and I think it's important that we keep that in mind. Certainly age is a factor. A lot of these medications are not approved for people under the age of 16. if you are 15 years old and you're an opiate addict, you cannot be prescribed Suboxone, for example. If they've had previous non-medication assisted recovery attempts that were not successful, they should be considered for medication. So, and I think that's really important to hear that, you know, if non-medication assisted treatment did not work once or twice, why try it again if there are other options? And medication is always one of those options. There has to be a consent, obviously, to treat with the medication. They should be medically and psychiatrically stable. So if they have a co-occurring disorder and they're on medication, they should be stabilized by that medication before being prescribed anything for their chemical addiction. I've already talked about pregnant women and the issue of medication, especially with methadone. Very important that you allow people to make wise, informed choices. And in this field, we tend to, well, let me do some self-disclosure. 20 years ago, when I was in non-medication assisted, when I was in abstinence-based counseling agency, I would never offer people the option of going to a methadone clinic. I didn't believe in it, and because I didn't believe in it, I felt it was they shouldn't believe in it either. I think we really need to look at our attitudes and how it impacts the way that we're treating people, and consider the importance of giving people choices, because that's where they're going to get their power back, by having choices. Okay, I have run out of time, and I apologize that I couldn't address everything. I hope I've addressed enough to at least whet your appetite. I am absolutely impressed that you all stayed online for an hour on a beautiful Friday. Don't forget to fold your fingers in this new order. I got a few of you that are going to try it out. And in the meantime, I'm going to look up that medication that was the TB medication, so that I can see where that is in terms of its use in recovery. This is Mike Gaudette. I've enjoyed spending this time with you. Please make sure to fill out the questionnaire. Please make sure to answer the quiz when you get it, so that you can get your CEs. And if there are any questions once we're done, and I do see that someone is typing, and I can stay long enough for that, but if there are questions after I'm done, get them to Kim, and she will get them to me. I just heard, somebody told me I did a good job. Well, thank you so much for that. It's my first time doing it on a website, so I was a bit intimidated by not looking at your faces. But you all made it very, very enjoyable for me as well. And I want to thank you all. Okay.
Thank you, Mike. I just want to say thank you as well. And for anybody that may not have noticed, the quiz and the evaluation is to the left of the page underneath the picture of Mike. You can upload that document and email it to me at your convenience. Or if you'd like, you can email me and request it, and I'll send it to you. There's also the PowerPoints. You can upload those as well for your own personal use. And if you have any questions, certainly give us a call at the office. Thank you.
And before you hang up, I have one question. Can I answer this?
Yes.
Is methadone withdrawal worse than heroin? That's an excellent question, and I'm glad that it was raised. Methadone's half-life is 24 to 36 hours. Heroin's half-life is 4 to 6 hours. So what you should be figuring out right now is that it takes a longer period of time to withdraw from methadone than it does from heroin. Anecdotally, I've heard from clients that it is more difficult, and in processing that with them, it's often because the withdrawal process is longer than it is with in terms of the sickness and the cravings, tends to take several weeks versus several days. So they will experientially report that it is worse than heroin. What we know scientifically is that it's longer than heroin withdrawal, and therefore it's a little more difficult. But there are ways in which clinics will assist people through that withdrawal process that unfortunately I can't get into time-wise, that I think helps them through that process. And Judith, we're going to hear one more line from a person who's typing, and thank you. It's a thank you for an interesting webinar. Well, thank you all again too, and have a great rest of your weekend. Take care all.